Welcome to the Healing Grove podcast. I'm Dr. Kristin, an integrative holistic family physician, author of Life After Lyme, and host in this virtual space of learning, healing, and growing. I believe humans are like trees, and our physical limb is only one of many. Health on all limbs of the tree, emotional, conceptual, social, spiritual, is absolutely required for the whole tree that is you to be vibrantly well. I created the Healing Grove podcast as a place to showcase some of the world's best integrative and holistic medicine, to expose you to transformative tools and mindset shifts for all limbs of your tree. I hope you enjoy our conversation in the Healing Grove today as much as I enjoyed having it. Hey, everybody. Welcome back to the Healing Grove podcast. I'm so excited today to introduce you to one of my mentors and friends, someone I learned a lot of what I learned initially about Lyme disease from. So everyone, this is Dr. Ann Corson. She grew up in Southeastern. Yeah, welcome. She grew up in Southeastern PA. She got her medical degree from the University of Penn School of Medicine in Philly and had residency training in not one, not two, but three different specialties: internal medicine, neurology, and family medicine, which she ultimately was board certified in, along with integrative holistic medicine. So she's currently double board certified. And actually the two things I'm double board certified in, I just realized that. She was one of the founding members of the physician training program, which is how I met you, right? Because I did that physician training program back in 2014 as I was in the midst of recovering from Lyme disease myself. I don't know if you remember, I was intermittently lying down on my back in your kitchen in between patients, still struggling a lot. So worked very closely with a lot of the people who are sort of considered the founding people in the treatment of Lyme. And actually, that was one of the reasons I really wanted to do my preceptorship with you. You know, I really felt like at that time I was disgruntled with the way in which Western medicine was approaching Lyme and, you know, basically missing Lyme all over the place. And I wanted to be with someone who knew what was up, but also had a really rigorous background in, you know, traditional Western medicine. And I don't know that I ever told you this, but I was just blown away by the level of thoroughness and care that you took with your history and your physical exam. Like, I don't think I've ever been with a physician who was as meticulous and careful and comprehensive, other than maybe in medical school when people were walking us through all the things you had to do. You were just amazing to watch. And I carry that with me. I appreciate that so much. So today
I had patients tell me that they had never had a physical exam as comprehensive as the one I gave them. And I was so surprised because to me, that was just what you did.
Yeah. So let's get into this. We're going to talk about hypercoagulability today, and we're going to wind our way through and to that. But first, I really want to hear you tell your story, Ann, about how you came into this wacky world that we both live in of, you know, diagnosing and treating Lyme, and some of the other issues that go along with it. Would you mind kind of walking us through your journey a little bit?
Sure. When my son, who's now in his mid-30s, was an early teenager, 13, 14 years old, he started to become ill and I couldn't figure out what it was. And he was just so sick and he couldn't get up. He was so fatigued. He had all these symptoms and I couldn't figure out what it was. And he was home from school. And so I was going to a myofascial massage therapist for a while because I'd had a problem with an injury to my back. And I was sitting there kvetching to the therapist about, you know, my son, and I couldn't figure out what was wrong. And he goes, "And he's got Lyme disease." I said, "Well, Tom, how can he have Lyme disease? I've done the ELISA 3 times. And he said, "Oh." And he handed me a flyer, and Burrascano was coming to talk at a local high school not far from here in a few months. It was May, I believe, of 2003. I think that was the year. And so I went to this talk and, you know, I had learned more and was more intellectually stimulated than I'd been in the last 15 years. And I met the people that ran the Lyme Disease Association of Southeastern Pennsylvania. I don't know whether they're still in existence or not. It was Doug Fern then who was running it. And they had a little symptom checklist book. So I took it home and I had made my checklist as to what I thought. And then I gave it to my son and had him do it. And he had even more symptoms than I thought he had. So I said, "Oh my God, you got Lyme." And so then I called up, and I'd listened to Burrascano, so I called him up and asked if I could come, watch in his office, because that's the way to learn how to do something, is watch somebody else do it, right? In medical school, you see one, do one, teach one, right? That's how you learn. So I went up there for the first time, I think it was June, and spent a week with him. And that's kind of what jump-started the whole teaching, because later in that summer, a doctor came from England to be with him. And then I went back again in September. So I spent 2 weeks with him. And then like a year and a half later, I went and spent a week with Dr. Jones in Connecticut. So I really learned from the fathers of, not only adult Lyme disease, but pediatric Lyme disease. And then the mold was another problem that I discovered in the house that we were in. We were an old farmhouse, and I realized not only that we were sick with tick-borne diseases, but that mold was a problem. And of course, at that time, Richie Shoemaker was the one who was the maven on mold. So despite his somewhat abrasive personality at times, and his clash with the Lyme world, I really learned a lot from Richie's work, and learned that most of my folks that were the sickest had a combination of mold and the Lyme, and that the mold was what was driving so much of the inflammation. Then I had a patient come in and put a bottle of Toxex from the Pecana company on my desk, because I don't know what this S blank 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 is, but I took 2 drops of it and I was sick for 2 days. I said, I got to know what this stuff is. It was Toxex, which removes toxins from the matrix. And she was a mold and Lyme patient. She was just chock full of mold toxins everywhere. So I started, I looked up the company that it came from, which was the Pecana, imported by Bioresource Incorporated, Mike Sheehan's company in California. And so they had a whole training program to teach you how to use these medicines. And it was run by a pair of brilliant chiropractors, Gary and Rain Klepper, Klepper. They were from Colorado. Well, I went to one of their lectures and I came home with this, 6-inch thick book, to explain how to use everything and all these concepts. And he melded the concepts of Chinese medicine, German biological medicine, which is where these remedies came from, that school, and Western medicine and physiology and anatomy. And it was just fascinating. So I kept going to all of those conferences, and I learned as much as I could from them and learned how to use the remedies. And then my patients started getting better a whole lot faster. And it was actually from Gary Klepper that I learned first about hypercoagulability, because he'd learned it in a lecture that David Berg had given. And David Berg was a fellow who had started a lab called Hemex that was doing all the lab tests to prove hypercoagulability. And Dr. Berg and a couple other doctors had, here you can see this was at the IDSA meeting a long time ago, where they had an exhibit and they showed that in 1,000 cases of chronic Lyme disease and borreliosis, that there were, almost everybody, you see this on the slide, 87% had low activation of coagulation and almost 90% had some sort of hereditary defect. So that the people that were chronically ill with Lyme were people that had some sort of coagulation problem, and they tended to be hypercoagulable. So I realized that this was a huge problem, because the people that I was seeing weren't the ones that were easy to treat, that went to their family doctor and got 3 weeks of doxy and were better. But these were the people that were sick, and they were not only infectious, but they were also toxin exposed. So I realized that this was going to be a very important aspect of their chronic illness that I had to address. So
Yeah.
I really hope that, other people would learn this, other physicians would learn this. But what I'd like to do, unless you have another question, is I'd like to talk about what hypercoagulability is, and then how we go about evaluating it and treating it.
Yeah, let's go right to your presentation, because I think you're going to answer most of my questions with that, and you have some beautiful slides.
Okay. Well, so I learned that hypercoagulability was really a serious problem in chronically ill patients. This was a study that was done by Kristin and Dr. Berg and Dr. Harrison, and they looked at over 1,000 cases of chronic Lyme disease, and they found that, almost 90% had some activation of coagulation, and a lot of them had hereditary defects. So there are a lot of hereditary issues that make you more predisposed to developing hypercoagulation when you have an environmental stress, such as infections or mold. So, what is the hypercoagulability? The body maintains a very delicate balance in between clotting and breaking down clot. So, we want to be able to stop bleeding as soon as we get injured, but we also want to be able to make sure blood is flowing freely. So a hypercoagulable state is when there is an overabundance of the molecules that are driving clotting over thing. And what that does is that results in the formation of excessive soluble fibrin. And this is the molecule that is made in the cascade of protein reactions, enzymatic reactions, that create a clotting milieu in the blood. So fibrin can exist certain ways as monomers, polymers, et cetera, or as protofibrils. And it often will accumulate along the lining of blood vessel walls and then create all kinds of problems. And so you get this sludge along the endothelial lining, which traps toxins, infections, and all kinds of stuff. And then that also affects blood flow out into the tissues, oxygen release into the tissues, toxin removal by lymphatics, et cetera. So what causes hypercoagulability? Well, anything that increases inflammation. So there are many, many things on that list, which you can read yourself, but some of the most important, I think, are the infectious agents. Cancer has been long associated with hypercoagulable states. Toxins are very important as well. And I think that people that treat mold-induced illness have to understand that the mold toxins also precipitate hypercoagulability. EMRs, biologically incompatible frequencies also can do it, unfortunately. So hypercoagulability in the body is often made worse by infections, trauma, inflammation. For instance, if somebody's got a chronic gut dysbiosis and I have all kinds of horrible products leaking up into the liver and the portal system and out into the bloodstream, then they're going to have all kinds of chronic inflammation and then hypercoagulability. Dental cavitations do it a lot. I saw it a lot with people who have Bartonella infections and have the vasculitis that Bartonella causes. And people, of course, who are full of mold toxins and, of course, heavy metals. You also get hypercoagulable flares with Herxheimer reactions and also with new mold exposure. Say you're treating somebody who is mold sensitive and they accidentally go into a store that's full of mold toxins and they come out and they go, oh my goodness, I just got a bad mold hit. Well, part of the mold hit protocols have to involve enzymes to break down the excessive soluble fibrin, or you're not really going to help people. And then I really enjoyed the work of Stephanie Seneff about the damage that glyphosate does to the body. And glyphosate can induce a sulfate deficiency. And if you have a deficiency of heparan sulfates along the endothelium membrane, that can result in a hypercoagulable state. And so it's also important to think about detoxifying not only from mold toxins and metals, but also from glyphosate to reduce exposure as well as detoxify from it.
All right,
so coagulation depends upon.
Let me ask a quick question, because I think people hearing this are going to look at that list and they're going to be like, well, maybe I have a little bit of that, but I don't have that. I don't have that. It doesn't have to be everything, right? You can have increased in your tendency to form clots from only one of those things, right? So you don't have to have genetics.
Oh yeah. Yeah. That's just yeah. I mean, 1 in 5 does, but even just one of those things can result in hypercoagulability. That's just a comprehensive list of the things that in my experience, in my practice, were associated with hypercoagulability. So yes, you could just have one of those and have a problem.
Yeah. So for people who are freaking out already, I just want to plant the seed for the listener, because I know my audience and I know they tend to get overwhelmed and freaked out. So I just want to say, like, we're going to get to some actionable steps if you think that you definitely qualify as someone who probably has more than their fair share of blood clots floating about in their body. Okay, so go on, Ann.
Well, it's not so much blood clots as it is excessive soluble fibrin. Now, after the jabs, then people did develop microthrombi. That's true. So they're also dealing with that if they were forced to get that. But that's a different story. Now, coagulation depends on two things, on the activation of platelets as well as the production of fibrin. And that's controlled by three different systems: platelet behavior, whether they're activated or not, fibrin formation, or fibrin degradation. So platelet behavior is rather easy to deal with, and we'll talk about that in just a second. Fibrin formation or degradation is what you really need to help with. So it's the degradation of the fibrin where treatment comes in, and trying to reduce those factors that are contributing to fibrin formation. So platelets aggregate and get sticky in response to lots of things, but in our patient population, it's usually due to inflammation and toxins and infections. So fibrin formation and degradation is based, and don't wig out when you see this, because I'm not going to go through this. This just lets you know that there is this physiological balance between clotting and unclotting, breaking down fibrin and making fibrin, okay? So it's just a balance that's there all the time in the body. And the formation of fibrin is really determined by several different factors. And what we see in our patient populations are acute and chronic inflammatory disorders. And sometimes we see cancers, but in my practice, I rarely saw cancer in my patients. It was mostly just mold and infections. Now, we're not going to get into the mechanics of clot formation, but we're going to talk about the consequences of the excess fibrin in the body. So you get this extra sludge layer, and what does that do? Well, it ends up resulting in congestion of both the milieu and the environment inside blood vessels, or intravascular, and outside blood vessels, or extravascular. And it results in both tissue and organ compromise, because nutrients and hormones and tissue factors can't get out of blood vessels, and metabolic weights and toxins can't get in for removal. You can't control vasodilatation and vasoconstriction on blood vessels that are rigid, because they've got this lining of sludge along the inside of them. And so that results in altered autonomic responses and blood pressure control. And I suspect that this may be why I saw a lot of syncopal type things and problems with orthostatic hypotension and things in my patient population, was that they just couldn't regulate as fast as other people. So I always ask them to get up slowly, sit on the side of the bed for a little bit before they get up. Now, this is just a visual representation of what happens when you only have 1 micron of soluble fibrin on the lining of the blood vessels. It reduces the oxygen diffusion across the endothelial by 500%. So we're talking about people having real compromise to their extracellular matrix, to their tissues, just with a very teeny amount of soluble fibrin. That's why I think it's so important for people to, practitioners, to address it. Also, when you go to remove this, and this is one of the caveats in treatment, which we'll get to, is that all kinds of stuff can be trapped in this fibrin sludge that's along the lining of the blood vessels. And when you remove this, you must do it slowly, because they can be, thrombin trapped in there, which is physiologically active when it's uncovered. Now, in this same group of patients that Drs. Chris, Berg, and Harrison had the presentation about, they looked at all of the different blood tests to check for hypercoagulability. And you see that among those, there were lots of patients who had increased fibrinogen. they had increased prothrombin fragment 1 and 2, increased TATs. We'll go over what these are. And I would really urge practitioners not to be frightened by the complexity of these blood tests, because they're really not that difficult to understand. And if you just go over and over and over you'll be able to understand it. It's really not that difficult. I tried to sort it out here. So you have molecules that make you clot that are procoagulant, and you have molecules that are anti-fibrinolytic that don't allow you to break down fibrin. They're red. They're on the clot side. These things help produce clot, right? Homocysteine and PT-PTT are things to check for, and they're a little bit different color. They're not, there's another little story. Anticoagulants are the things that our body makes to break it down. And then the D-dimer is a measure of the fact that fibrin's being broken down. If you don't have an elevated D-dimer when you're actively working on getting somebody away from hypercoagulation, you're probably not doing a good enough job.
Well,
So,
let's hang out with that thought for one second, because I want to just name that for people who go to their physicians and ask to get clotting labs, often one of the things they're usually just looking for PT and PTT, and they're looking for D-dimer. And most physicians would see an elevated D-dimer as an alarm bell and think that there is an active clot that they have to worry about, like a pulmonary embolus, for example. Talk to us about.
Well, that's true, because
yeah.
Oh, that's true. Because if somebody is not in any kind of a treatment, but if you are a practitioner who is treating somebody for hypercoagulability, and you have them in care, you have them on the right enzymes, you have them on the right drainage medicines, and they're clinically improving, then following the D-dimer is not terribly important, but you can see a rise in the D-dimer and then a fall off again as you are cleaning up the body. But yeah, high D-dimer is something to look for. So you'd have to have, that's not that important a test. Like I didn't often check that test in my own practice very much. I found things like the lipoprotein A, the Pi1, alpha-2 antiplasmin were more important, as well as the protein S and C activity, because the protein S and C had genetic components. So I didn't bother with the D-dimer a whole lot. And I would just, it's more important to follow the other testing.
Yeah, agreed. I just want people to know that their doctor may not have seen this lecture and might freak out if you're on treatment for this hypercoagulability and you get an elevated D-dimer. It's actually expected and normal to have an elevated D-dimer when you're treating these situations. But I just want to make sure the listener is clear about that, because often people will take information from a talk like this and they'll go to their doctor, and their doctor doesn't have any context or actually the education that they need to know what to look for and how to interpret it properly.
So this just explains, what these tests are, and it's pretty explanatory here. So these are just elements that are increased when there is a problem with clotting. So this tells you that the immune system is being activated, and the coagulation cascade has been activated. Then this is really more complicated than is needed. I don't think we really need to be worried about that at this level. These are also testings that help you know whether there is going to be a problem. Like activated protein C resistance is most often caused by a factor V mutation or factor V Leiden mutation. Prothrombin can be up. Lipoprotein A can be a genetic marker. Some people just have high lipoprotein A's in their family, like some people have high cholesterols. It can also be elevated in certain kinds of cancer. Alzheimer's disease or with myocardial infarction, and it can be elevated with inflammation as well. So these are things to look for. Alpha-2 antiplasmin is not going to be up unless you're hypercoagulable, and Pi1 blocks fibrinolysis, and there are different genetic mutations of the plasminogen activase inhibitor 1, and the 4G allele is the worst. They tend to be stickier. Homocysteine, again, the best level for that's between 6 and 9. If it's too high, it creates problems. If it's too low, also. Some of the things that are important to test are antithrombin activity, protein C activity, protein S activity. These three should be in a 1-to-1-to-1 balance within about 10 points of each other. And if they're not, then that shows that there's some sort of upset in the balance of the coagulation cascade. Often a low protein S can be an indicator of a chronic hypercoagulable state because the body is consuming the protein S and it's going to be, chronically low. And it's really a physiological adaptation to a hypercoagulable state. So these were the normal reference ranges that you want to have for these tests. And of the slides, throughout this whole presentation, this one and the following one are probably the most important. So you've got a normal range here, and then you've got the reference ranges for a lab called Esoterics. When Esoterics ended up being bought by LabCorp, and then LabCorp was doing these tests, and I don't know whether it still is or not. But so I used to send my patients to LabCorp to do these tests, and some of the tests aren't available anymore. But this is the normal range for the first, and then here's the second. So these are important slides to either copy or write down so that you have an understanding, because sometimes, the reference ranges in your laboratory, routine laboratory, are going to be way off.
I was just going to say, just for listeners so they know, so LabCorp still will do those tests, but you can't just order them independently of a very special panel code. Ruth Kriz, who you and I both know, who works with interstitial cystitis and hypercoagulability and biofilms in the bladder, created a panel and worked closely with LabCorp so that they will always not only do the right tests, but then reflex the tests appropriately as needed, because they were, sending the Pi1 people who were high off to be reflex versus, they just had some glitches. So she kind of corrected that. And so if people are interested in the LabCorp panel, we can let people know.
Oh, that's great. Yeah, I had made up my own lab slip that I used to send out to LabCorp for it, but I'm glad that she's done that with them, probably from their headquarters. That's excellent. I'd also like to, have that. Does she share that lab slip?
Yeah, absolutely. I'll share the panel number with you.
Oh, yeah, that would be great. Okay. Do you want me to talk about genetic variants or no?
I think, it looks like we have a few slides there. And I think it's important for people to understand because, like you said, 20% of the population has at least one of these variants. And the percentage of people based on the study.
Actually,
more than that.
Actually, yes, it's about 30% have some genetic abnormality. 7% of those are bleeders, right? So they're either von Willebrand's disease or abnormal factor VIII. Those are hemophiliacs.
Mm-hmm.
But the 20 to 25% are hypercoagulators. So 1 in 5 are hypercoagulable due to low-level activation of coagulation. So 1 in 5 people walking around on the street have a problem with a genetic variation that when they have a environmental factor, they are more likely to then become hypercoagulable because of their underlying genetic, what their genetics are. And when you look at chronically ill patients, up to 95%, that's my opinion, are hypercoagulable, and that was saw that in the original data from that study of 1,000 Lyme patients. So what are the common genetic variants? Well, you make too much thrombin with factor V Leiden, and that's pretty common. And you'll see elevated prothrombin, which is factor II, and activated protein C resistance. You can have weak breakdown of fibrin, fibrinolysis, or hypofibrinolysis. And protein S has several hereditary defects, and protein C has several hereditary defects. And Sometimes the hypercoagulable states can be due to the chronic stress and the physiological adaptation rather than a result of a genetic weakness. So I would test when I would first see patients, and then as they got better, 6 months or even a year later, I would repeat the abnormal tests to see whether they'd return to normal. A person who had a genetic weakness would not return to normal. So you can check for a true genetic weakness by retesting after treatment, and you supposedly have rebalanced everything. So the common variants include decreased fibrinolysis, not breaking down fibrin enough, and you see an elevated lipoprotein A, you see an elevated alpha-2 antiplasmin, elevated pi1, and again the 4G is the worst, and elevated homocysteine. And when you see an elevated homocysteine, make sure you check for an MTHFR variant. It's usually the C677T or A1298C that are most commonly associated with a homocysteine being high. And most chronically ill folks have some genetic issue with one of these, again, with either protein S, protein C, antithrombin 3 deficiency, elevated lipoprotein A, alpha-2 antiplasmin, pi1, or factor V Leiden. So these are the most common genetic issues. Now, it's not the end of the world. People go, oh my God, I've got a genetic issue. No, it's not. 1 in 5 people walking around the street have some sort of genetic issue. I mean, it was to your advantage in the past. I mean, if you could clot as you were running away from the saber-toothed tiger who slashed your leg open, I mean, you were going to survive better if you clotted quickly, right? So, it's not a bad thing. It just is a fact of life. And we didn't used to be so exposed to indoor toxic mold and these chronic infections as we are now. So it's a maladaptation that has occurred as a result of other environmental and infectious influences. The SARS-CoV-2 spike protein was also associated with the development of a lot of microthrombi and hypercoagulability. And that's really all that I'm going to say about that. What are the symptoms of hypercoagulability? Well, you generally get a pain that can be debilitating. People complain that their limbs fall asleep easily. They have painful numbness in the distal extremities, especially the feet. They have deep, achy, sharp stabbing shooting pains that come out of nowhere, like kind of a sharp lightning bolt pain that goes from, say, the middle of your arm down to your hand. And it's like, why does that hurt? Sort of neuralgic pain that goes along sort of nerves. They can get brain foggy, be quite encephalopathic, be irritable, anxious, very labile up and down affect. Insomnia is a huge one, with or without restless leg syndrome. And then during daytime, the people that just can't sit still, they get up, they move around, they change the legs that are crossed. They're moving all the time during their interview with you, and they just are, it's like an akathisia or a restlessness, and often that can be indicative. It doesn't have to be, but it can be indicative of being hypercoagulable. Often they're stiff and pain upon awakening in the morning, or they're stiff after being sedentary on the couch for a couple hours watching TV at night. They get up and they go, oh, and they sort of, groan to stand, and it hurts to take for a couple steps. Sometimes nausea in the morning upon awakening, or having a very poor morning appetite. It can mean that they're hypercoagulable. Sometimes people complained of painful teeth or the sensation of their teeth being loose. And that went away once I addressed hypercoagulability. And then they have horrible aerobic exercise intolerance. They get worse pain with exercise, they get short of breath, and they just have horrible fatigue after any kind of exercise. They can be encephalopathic when you have signs, you're looking for them, you're observing them. They're irritable, they're emotional. They often have mottled skin. Be sure to examine people's skin and examine their bodies. I really can't stress enough how important it is to not only take a history, but to do a physical examination of your patient. You will learn a tremendous amount, and you're not going to get cooties from touching people. It's just, it irritates me so when doctors don't utilize all the tools that they have at their disposal to evaluate patients, and a physical examination is one of the most important. often will have cold and clammy distal extremities, but they're warm in their trunk. Sometimes if this very extreme, you can have a pale swollen tongue with scalloped tongue edges. And then you look underneath and always look at the sublingual veins underneath the tongue. And when you go to examine the abdomen, sometimes it's sort of a doughy feeling, and they're often tender right around the umbilicus. Often there's soft tissue congestion. It's hard to find veins sometimes on these people in order to draw blood because there's just the soft tissues and the extracellular matrix is just congested. And when you lay them down, sometimes their head gets really red and swollen looking, and then they want to sit up so they don't feel well. Sometimes when their feet are dependent, they get really purple, and then they're better when they go up. And then look at capillary refill in several digits as well as toes, and sometimes in, over the thenar eminence or the hypothenar eminence, and, look at the refill. If the capillary refill is more than 2 seconds, then the person has a problem. Do you have any questions about the signs and symptoms?
Yeah, I mean, it's so fascinating to me just how varied the presentation can be. And I think the way I think about it is they all stem from either lack of adequate blood flow or poor removal of waste products and resulting congestion. Are there any other mechanisms involved besides those, or is that kind of the way we can understand each and every one of these?
Well, I think that those are the results of the problem with excessive soluble fibrin along the lining of the blood vessels. So that's the end result. So you're going to see, problems also with blood pressure control, right? Because you can't change those arterioles very well. So those are people that are think of those things as well. Yes, I really believe that that's so.
How about the periumbilical changes in the skin? Like, to help me understand sort of anatomically why it would show up in that way.
If you're not getting enough blood supply to your organs, your gut is very sensitive. So if the gut and the abdomen are diffusely tender because it's not getting enough blood flow, where is it going to be most tender? It's just going to be diffuse. And it's usually, most of the intestine sits in the periumbilical area, right? Most of your small intestine, and then your colon is around all the edges. So if you're not getting enough blood flow to the vast majority of your intestine, then that's where you're going to be most tender on physical exam. You may not realize it until somebody actually gently touches your abdomen. I would put my hand on people's abdomen and put one hand over the other, and then just very gently push down until they went ow or something. And I would always examine in all 4 quadrants as well as in the epigastrum below the xiphoid, because you really want to feel the whole abdomen, and you really want to feel all quadrants. And there is a sensation that you got to the pliancy of the tissue, which after a time you got used to it. You could almost feel that congestion in the gut, and it was very typical.
Yeah, fascinating. Thank you.
So let's talk a little bit about treatment. So the basics in treatment of hypercoagulability is first to help reduce the inflammation. And there are lots of things that are common in the naturopathic, German biological medicine, Chinese medicine world that are done to reduce inflammation. Of course, you want to get your fats right. You want to make sure the liver's detoxifying. You want to address gut dysbiosis. You want to use drainage medicines to start cleaning extracellular matrix. Then you can go in and treat your infections. Always make sure a patient is hydrated adequately with water, not juice or not soda. It's amazing when you actually take a diet history, and that's another thing that I don't think enough doctors do is to take a good, adequate diet history. And they can have their staff do that, or they can have patients go home with a piece of paper and write down everything they eat for a couple of days out of the week. It'll really give you a good idea of what they're eating, because if the diet isn't clean, then you're going to have a lot harder time. So it's really important to address that. Most of our folks, when they're really sick, can't exercise. Going upstairs is a trial, but eventually exercise is helpful. And of course, stress. A lot of them have insulin resistance, or they have some sort of metabolic syndrome. And that is where diet is very important, because they really have to stop the intake of pesticides, herbicides, glyphosate, all kinds of metal toxins. They have to really get squeaky clean. And it's hard because we're so polluted. And then again, to treat the hypercoagulability, the first thing is to decrease the platelet activation. Remember, I said that's pretty easy to do. Allopathic medicine uses 81 milligrams of aspirin a day, and that's fine if your patients want to do that. I never had problems with people on 81 milligrams of aspirin and fibrinolytic enzymes, which we'll talk about, having bleeding problems. In fact, I never had anybody on the enzymes that I use ever develop a bleeding diathesis. And people are always worried about that. Oh no, they're going to bleed, but it didn't happen, at least not in my experience in all the years that I did that. Again, omega-3s at high doses, vitamin E and other herbs and like ginkgo and stuff really help to decrease platelet activation. So what's the mainstay of hypercoagulability treatment? Well, you want to get rid of the excess soluble fibrin. And there are two main ways to do that. One of them is with heparin or Lovenox, and the other is with the fibrinolytic or proteolytic enzymes. So hopefully not many of your folks are going to need the Lovenox. I really didn't need too much of it. I did use it upon occasion, but it's painful to use. It's expensive. A lot of insurance companies won't use it, but sometimes it really is very helpful when someone is quite sick. Other than that, I did very well with fibrinolytic enzymes. And it's very important to start your doses low and gradually increase as the debris, toxins, and infective agents are released. You want to do it very slowly, because you don't want to overwhelm the exit pathways, right? You don't want to overwhelm the body's ability to detoxify what you are letting loose. Then there are herbs that, can help, and other homeopathic immune modulators, some of which unfortunately aren't available anymore. So you want to eliminate the root causes of the hypercoagulability as you are doing all those other things to clean everybody up. You want to try to get rid of infections and toxins. And I just listed those. Petroleum byproducts are another one that are pretty common, actually, and other environmental toxins. Mold toxins, of course, are some of the most important, as well as heavy metals. People really need to address it if they have metals in their mouth, and they really need to get their amalgams removed. And then you want to try to buffer the genetic weaknesses that people have. They may need fibrinolytics whenever they get stressed for whatever reason throughout their whole life, if they're, particularly weak genetically. So what do you use to treat? The first of the fibrinolytics is nattokinase. Nattokinase is derived from natto, which is a soybean fermented with Bacillus subtilis. It closely resembles plasmin, and plasmin is the major rotoruter that breaks down fibrin. It can dissolve soluble fibrin and existing clot or thrombus directly. So it acts right at the site where a clot or a thrombus or excessive soluble fibrin is. And it also helps enhance the body's own endogenous production of plasmin and other things such as urokinase. So it not only directly breaks down fibrin, it also encourages the body to break down fibrin. It decreases some of the things that we look for. The nice thing about that, they can be orally administered. The action is 8 to 12 hours, so you really only have to treat BID, sometimes TID if somebody's really sick initially. It can help lower blood pressure. Not only does it do that by opening up the sludge in the arterioles and allow better control of contraction and dilatation of the blood vessels, but it also acts a little bit like an ACE inhibitor, at least in some studies. And then it really clinically helps people who have abnormal platelet aggregation and the people who have cardiovascular disease, peripheral vascular disease, hypertension, diabetes, dementia. So it's really has broad clinical usage, and it's a whole lot safer than things like warfarin. Lumbrokinase is another fibrinolytic enzyme. It's more powerful. It comes from the earthworm, and it really dissolves fibrin. It's very, very potent, and it also decreases fibrinogen, and it markedly reduces platelet aggregation. It's very poorly absorbed orally. So you really have to have people take lumbrokinase on an empty stomach, because one study showed that only 10% of the enzyme could pass through the endothelium intact into the bloodstream. So you really want to make sure that people are taking it empty. Otherwise, they're just wasting their money. So the nice thing about lumbrokinase is that it's active only when there's fibrin around. Now, the other ones that are used in medicine, like streptokinase, urokinase, or TPA, they will work even if there's no fibrin, but lumbrokinase only acts on fibrin, period. So if you don't have any excess fibrin, or you've dissolved all your excess fibrin and you still are taking lumbrokinase for a while, it's not going to hurt you. It's very, very specific to fibrin. Therefore, it has a very, very low risk of causing hemorrhage due to excess fibrinolysis. And it can be incredibly helpful in breaking up biofilms, because biofilms are often surrounded by a shield of fibrin and all kinds of debris. So these were just studies where they actually used it in. This is a clinical medicine here. The stroke patients did better without a risk of increased bleeding. And this was a Chinese study that showed that treating patients, ischemic stroke patients with lumbrokinase for a year, really reduced fibrinogen levels and decreased plaque and decreased the carotid artery intima media thickness. So, why aren't all stroke patients and cardiovascular disease patients treated with fibrinolytics? I don't know. They should be. So I also treated during pregnancy and used heparin as well as these in pregnancy. Our pregnant patients that are sick with mold and Lyme present interesting challenges. Now, I just have a few treatment caveats here. The body's endothelial cells generate thrombolytic enzymes routinely, but this activity declines with age. So as people get older, they tend to get more hypercoagulable because the thrombolytic or breaking down thrombin enzymes are not made in as much abundance as they had been. All chronic diseases of the capillaries worsen hypercoagulability. And anytime there's a problem with blood vessels, especially capillaries, hypercoagulability is worsened. People who have uncontrolled infections or ongoing mold exposure will continue to be hypercoagulable. So in addition to treating the hypercoagulable symptoms and signs, you must deal with the uncontrolled infections and get people out of mold. There's just no substitute for getting people out of mold where they're no longer being exposed to mold toxins. That is the most important thing. And when you treat these infections and you remove the toxins, often the driving factors that create the hypercoagulability will go away. So you can taper off treatment once the infections and the toxins are removed. So when you go to remove people's heavy metals and you go to move mold toxins out of the body, the movement of those things from the extracellular matrix or intracellular, wherever they are, through the lymphatics, through the bloodstream, to get excreted by the kidneys or the gut, worsen the hypercoagulability and its symptoms exponentially. Mold toxins just trigger it like a house of fire, as do heavy metals. Also, when people have Herxheimer reactions to the die-off of Lyme, as well as toxic mold exposure, where they walk into a place that's moldy, that also can cause increased inflammatory cytokine and soluble fibrin production together. So we had a mold hit protocol for my patients where if they got into some place, they get out as soon as they could, wash their face and hands, immediately take some anti-inflammatories, which I used to block the cytokines, and enzymes as well. So that was just part of the mold hit kit that I made people keep with them all the time. Always had enzymes with that. So how people would ask, well, what do you do when somebody comes and they're already on Coumadin? So to wean people off Coumadin, follow the prothrombin fragment 1 and 2. Use fibrinolytic enzymes and titrate just up slowly as you're coming off. And then use something to decrease platelet aggregation, because that's the one arm of the coagulation cascade that's not being dealt with Coumadin. Coumadin blocks all of the coagulation factors, so that the whole coagulation cascade of fibrin formation, doesn't happen. So, but you still have platelet aggregation. So there you would use the high-dose fish oil, vitamin E, and so you can do that safely. You just have to go up very slowly on the fibrinolytic enzymes as you come down on the Coumadin. Rarely, sometimes when you are treating with fibrinolytics, you can have a paradoxical worsening before they get better. And again, this is due to, it's believed it's due to thrombin that's been trapped in this fibrin sludge layer that was uncovered and become active again. So you treat that by increasing the fibrinolytic enzyme doses significantly for a little bit until symptoms resolve. And then sometimes you need to add heparin, either subcutaneously or intravenously. Don't back off. Backing off treatment and saying, oh no, I gave them too much enzyme. They feel like, they feel lousy, so I'm going to back off and stop the enzyme. That doesn't help, because you just added more fire to the stove, and you just made it hotter instead of cooling it down. So you really need to continue the treatment there if someone starts to get worse before they get better. So hopefully now you understand a little bit more about what the fuss about fibrin is all about. I'd be happy to take questions.
Amazing. Well, okay, so I have some questions. I'm trying to represent my audience for whom this is new. I guess the first thing I want to maybe just clarify. So it sounds like it really is important to go slowly as you're implementing any kind of fibrinolytic therapy, such as Baluch, lumbrokinase rather, or nattokinase, the things that can, kind of almost rotor-rooter into these biofilm or fibrin sludge layers and create initially more havoc before they resolve it. If you get ahead of yourself and are giving too much or finding that you're herxing, it also sounds like you shouldn't back down, even though maybe you started with too much. You should go higher on the dose. Is that what I heard correctly?
Well, no, it's sort of a balanced game. So if you've gone too fast and you dorked somebody, you did too much, then it's important to stay at least with the level that you are treating with, or you can back down just a tiny bit, but don't stop. Again, if you stop, then you're going to have all that sludge. What you want to do is you want to add drainage medicines. You want to add things so that their lymphatics will drain, like Iteries from the Pecana company, or you want to add something to drain the kidneys to help the kidneys. I used to use a lot of parsley from Nutrimetics, or I use Renolix from the Pecana company, or sometimes if there's a lot of debris in the matrix, sometimes something like Mundipore from Pecana can be very helpful to help clear some of the debris. So I would use remedies that helped with drainage and regulation, and add those, and rather than stopping the enzymes. And then, of course, you would want to add an appropriate antimicrobial for whatever organism you have unleashed. If it is Bartonella, or if it's, some sort of mycoplasma or something, you're going to have to cover organisms with some sort of a broad spectrum antimicrobial. I like the Research Nutritionals products. I like the Supreme Nutrition products. There are a lot of really good herbal and combination herbal remedies, which are really good to use. That's a whole nother talk.
Yeah, no, but I think it highlights the importance of not just going at this willy-nilly. A lot of people might hear this and say, oh, well, I have all those symptoms and I know I have a clotting genetic issue or I have these inflammatory things, and maybe I'll just get on some Baluch. And there are some risks here, right? There are some downsides, and you have to be working with someone who understands how to help you walk through this and mitigate the downsides and the Herxheimers. So just want people to hear
Yeah,
that this is
I would please really advise people not to try to do this themselves, because I think, oh, well, I'm just going to go order some nattokinase and I'll be fine. Also, there are tremendous brand differences in how well these enzymes work. I'll just tell you the ones that I think have been the best throughout the year, throughout my years of practice. The Allergy Research Group gel caps nattokinase is the best one. That survives best in the gut in order to be absorbed. And then the Baluch brand of lumbar kinase is the only one that works, and that's made by Canada RNA. They had the original patent on the Japanese, formation of lumbar kinase, and it is the best. You can get all these other brand knockoffs, but they just don't work as well. And if you're not using the real McCoys, then you really need to change to use the ones that really do work, that have been tried and tested over the years.
Yeah, agreed. So if somebody's listening to this and they say, wow, I really would like to explore more about this, I'd love to work with Dr. Corson, is there a way for people to work with you currently? And if so, can you tell us what that looks like?
Well, the only thing I'm able to do now with patients is a consultation. I'm not actively treating and following patients. So if a patient wants a single consultation, either by themselves or with their current treating practitioner, if that practitioner is willing, then I can do, video conferencing in order to help them. I would do an hour visit with them. I ask people to provide me with a brief, not a 20-page, but a brief history of their illness, what they've tried, what they haven't tried, what their problems still are, who they've been treated by, and then let me review that. And then I can do a consultation with them and tell them where I think they should go. But I am not treating patients on an ongoing basis. I'm only doing consultations.
Great. Okay, so we'll provide access to a way to get in touch with you in our show notes. Is there anything else, Dr. Corson, that you feel like would be helpful to say that hasn't yet been said to this audience of wellness seekers who might be struggling with some of the things that you brought up today?
I think the most important thing is to make sure that you are not living in a moldy environment. If you're living in a moldy environment, you're not going to get well, and you have to face it and you have to deal with it. A lot of people have a really hard time accepting the fact that their home, which is where they live, and their castle and their domain, is what's making them sick. If it is, you really need to deal with it. And that's a real upheaval, but it has to be done. You won't get well otherwise. All these other issues, the hypercoagulability, the infections, the chronic Lyme disease, all this stuff will never get better if you're in a moldy environment. So I found that the most chronic patients in my practice weren't chronic because of tick-borne disease. Yes, they had chronic tick-borne diseases, but the reason their tick-borne diseases were chronic is because they had chronic inflammation, chronic cytokine production, and chronic hypercoagulability from ongoing mold exposure in their homes, in their churches, in their workplaces, in their YMCA that they went to once a week, or to the stores where they worked, or whatever. But That's the most important thing. Get out of mold.
Awesome. Couldn't agree more. So I think we're going to end it there. Thank you again so much for your time, for your wisdom, for all the years of mentorship, and for your vast experience that you're willing to share today. Really, really grateful for you.
Thank you for asking me. I enjoyed speaking with you.
I hope you enjoyed this episode of the Healing Grove podcast. If you liked it, please be sure to like and subscribe. And if you want to deepen your experience further, consider grabbing a copy of the Healing Grove Playbook. With journal prompts for this podcast and 41 others, it's the perfect place to record your learnings, keep track of the tools you explore, and reflect on your own experience. Finally, it's important to mention that even though I am a doctor, nothing you hear on this podcast, whether from myself or my guests, constitutes medical advice. Any intervention you try should always be discussed with and supervised by a trusted member of your own healing team. Thanks for listening, and see you next time in the Healing Grove.